Thank you very much, Marco, and good morning, friends, colleagues. So the question is, can we predict ACL injury? And then there's an additional question added to that, that's if not, what should we do? I have no relevant disclosures. But this is what this lecture is about, a video shared with me by my friend and colleague Rolf Rekik from the study we did here at Aspetar, and you'll get this. You get the idea, an ACL injury, this time in a male professional football player. And the question is, all these tests that you're all familiar with and we're all doing in our clinic, can we use them to predict who will be the guy who will be carried off the pitch with an ACL injury? Will it be him, or will it be him, or will it be him? And I'll start by quoting my favorite philosopher, Dolly Parton, who says that if you want a rainbow, you got to put up with rain. So the next 30 minutes or so, I will be discussing likelihood ratios, predictive value, and I'll also get into the characteristics of ROC curves and then the area under the curve, which is really the number that we're looking for. Sorry, just kidding. All right, I'll spare you all the math and try to tell you the story, which really started a while ago in 2009 when the IOC convened this group of hopefully experts who wrote a consensus-based statement on the periodic health evaluation of elite athletes, or the screening exam of athletes. And yes, that is you on the right back there, Juan Manuel. You've seen yourself already. So among the many topics or reasons why you might want to do a screening exam listed in this document, one of them relates to the topic of today's talk, and that is, can you identify the high-risk athlete? And what the conclusion was in 2009 was really, we don't know. That large population-based studies are needed to evaluate which components of history and examination and tests can be used to identify the athlete at risk and then intervene and change the outcome. And also recommendations to do like what we have done here at Aspetar, and that is to set up our screening program as a research project collecting data over years so we can learn from that data set. Now, to answer that question, in my mind, 3 research steps are needed. First of all, we need to do prospective cohort studies to try to identify potential risk factors for an injury and then define a cutoff. If you're below this value or above this value, you're at greater risk. And if you're not, then you're okay. And there are numerous risk factor studies out there in the literature on ACL injuries, on different types of injuries, hamstring injuries as well. But much of this, to the benefit of this talk, has been done on the ACL. So that's the first step. You need to know the risk factor and the cutoff value. The second step is you need to validate the test that you're using to identify the athlete at risk in not just the first cohort where this prospective cohort study was done, but you need to validate that it also works in other cohorts, because they may differ, younger, older, different gender, different level of athleticism. So it may not be that your first observation of this being a risk factor in this population applies to all types of athletes across all sports. So that is needed as the second step. But then there's also a third step needed. And that third step is that we need to do a randomized control trial to test the effect of a combined screening and intervention program to prevent injury. And the question then is, how does this need to be done? Because in my opinion, it would have to differ from the normal randomized control trials we do, and I'll explain how and why now. So let's assume that this is a bunch of athletes. So this is a large cohort, could be thousands of athletes that are in this cohort, probably should be. And if you use a test then, some of these, the ones in dark here, will be detected as having increased risk based on that test that you're using, okay? So for the study, we don't know yet who they are. So we have to split this big cohort into 3 different groups. Normally you have 2 arms to a randomized controlled trial, but to answer this question you need 3 arms to the randomized controlled trial. So the first group, you do a screening test. The second and third groups, you do not do a screening test. But of course in both groups there will be individuals with increased risk. Only if you don't do the screening test, you don't know who they are, right? But in the group that does the screening test, we know who they are. So the next step then is that's the whole basis of this, right? Is that the ones who have increased risk are given an intervention. But the ones who do not have increased risk, or you think have increased risk, they get no intervention. So this is group 1. Then what about the 2 other groups? Well, what I think needs to be done is that you have one group that is not screened and does not get an intervention, but you also need a third group that is not screened, but everyone gets the intervention. So this is the design that is needed to answer the question. And what can we expect then in injury rate? What is the whole purpose of this? Well, if we look at this, we have the 3 groups. Well, of course, what we're hoping for is that injury risk will be lower in the group that is screened and gets the intervention than the group that is not screened and doesn't get an intervention. Okay? That is what we're hoping for. So, third step, check. Or, did you start thinking now too? There was a third group there. What about this third group? They are not screened, but they all get the intervention. Where would you think that they end up? Here? No, I would say probably not. Here. It's pretty obvious, isn't it? Everyone is getting the intervention. Both those who have increased risk, or you think have increased risk, and the rest of the group. So that is the first message of this talk, is that if you give an intervention to all the athletes in the group, your injury rate is going to be lower than if you have a screening plus intervention program. Then the next question becomes, is it even possible to identify the athlete at risk with screening tests? All right, so what we're looking at here is advanced fortune telling, right? So the question is it a boy or is it a girl, based on a test? And we fortunately have a philosopher here at the hospital as well, who stated at one point that I can predict the sex of an unborn child at 2 days into a pregnancy with 50% accuracy. And I think it's that's a pretty accurate statement. But if you look at the picture of this guy, would you trust him? So can we do this better than flipping a coin? That's really the problem, or the question. So let's start looking at some screening tests. What do they really do? Well, first of all, this is the model, the most basic model for causation of injury, published many years ago by Winnemoy-Vissa. So first of all, we think that there are some intrinsic risk factors, some characteristics with the athlete that can put him, predispose him or her for an injury. Then what happens in sport is that they're also exposed to external risk factors. It could be the surface, it could be the shoes that they're wearing, it could be the snow conditions in winter sports, it could be any external factor. And together, these are what we call the risk factors for injury. And then, when the injury happened, the inciting event, the characteristics of that is also relevant. How did this really happen? Which is what we call the mechanism of injury. And here's the important point. When we're doing screening tests, what are we looking at then? Well, we're looking at the characteristics down in the lower left corner here. 1 or 2 or 3 or different physical measures of the athlete. And the question, can those explain that which is happening over in the end to the right? You're all familiar with many of the screening tests that are being used in sports, and here is a selection of them. We have strength for hamstring injury, we have functional movement screen or FMS for any type of lower extremity injuries, we have tests for shoulder injury, and we have tests for the ACL. What characterizes all of these is the following. If you have on the one side here the horizontal line, the screening score, so this is the score for each athlete on the test, and I put the number of athletes on the vertical axis, that distribution will look like this. Some will have a high score, some will have a low score, and the majority will be somewhere in the middle. So this is the basic traits of any type of physical test. So the question then is, if we now take this group and follow this group prospectively, let's say for a season or a year, and we then find out who gets injured and who is not injured, then we can split this graph into two. So the lower panel are the ones who stayed healthy throughout the whole season, and the top panel are those who were injured during the season. So if this were the distribution, we would say, well, we need a cutoff value to say, well, if you're lower than this, then you have increased risk. So if we draw the line here in the diagram, somewhere in the middle, well, we'll capture 50% of the people who are injured by the test. But the problem is we're also capturing 54% of the ones who are not injured, right? And it doesn't help us to move the cutoff value further to the left. We still capture the same proportion as being at risk and not being at risk. We can move it even lower. The same thing will happen. The same proportion is captured in both cases. And we can move it up and you get it. We'll still capture the same proportion of athletes as being at risk. But let's see then what happens when the groups differ more. So obviously there was no difference between the two groups in their mean value on this screening test. So this is the starting point. Now if I just move by playing with numbers all of the athletes in the top group by 15 points to the left, then if this were the result, would capture 99% of those who got injured, and we only capture 4% of those who were not injured. So how many of you think that this is a good test? Raise your hand. 2 hands, 3 hands. All the hands in the room should be in the air by now. This would be the perfect test as a screening test for injury. So, but let's make the exercise a little bit more difficult. Moving it by 1 point. What happens then is that the mean value becomes statistically significant. So if you read this paper, the abstract will say that there's a significant relationship between this factor that you're measuring, this test, and the risk of injury. Okay? Where's the cutoff value? Well, this is the optimal cutoff value for this data set. Trust me on that. We capture 50% of the injured, but we also capture 45% of the non-injured. Can we use this test? Anyone? No. So we're going to continue the exercise. Here I moved it 2 points to the left. Highly significant, really impressive study showing that this is a risk factor, right? But the properties of this as a screening test to predict injury means that we capture 61% of the injured, but also 42% of the non-injured. I'm now going to do a little bit of an exercise. So I'm going to move this by 1 point and 1 point and 1 point. And when you're satisfied that this is a test that I think that I would use as a screening test, please stand up. In the end, you'll all be standing, so there's no question about it, okay? 3 points. You see the properties here. 61, 38 are the numbers. Anyone? 4 points. 70, 38. 5 points. 1/2 standing, okay? 6 points. Okay, 2 more. 7. Looks like quite a few people are happy with a test where you capture 80% and no more than 20. Okay. 9 points. So about half of the group is now standing for those of you who are on the internet. 10. Okay, so we're at 10 points now, and pretty much the whole group is standing. Thank you very much for that. So in other words, what we learned from this is that there is a big difference between a statistical association as shown by p-values when you read these abstracts and the ability of a data set like this or a test like this to predict. It's two completely different types of statistics that are needed, the ones that I mentioned in the beginning of the lecture. But hopefully this was a little bit easier to understand. Okay, so let's have some look at some real data then. For the ACL, which is the topic of today, we have perhaps two main candidate risks. So FMS, functional movement screen, and drop jump tests. Those are the ones that are most commonly being used to identify risk of ACL injury. So let's start with the FMS. So this is a paper that came out of this institution at Aspetar, where we tested all the professional players in the QSL, the Professional Football League in Qatar, and these were the results. You recognize this? So that was the first figure I showed you. So basically, did not work, cannot work as a screening test. And not long after, Rob McCunn wrote this review paper where he looked at all the different studies done on the FMS, and his conclusion was very clear. It does not work. The FMS cannot be used to predict injury. So let's forget about FMS. I hope I'm not offending anyone in the room, because of course you can have your own opinion on the FMS, but the facts speak for themselves, and you can't have your own facts, as my other favorite philosopher, Ricky Gervais, says. But of course, it's important to be very careful about quotes from the internet, as Abraham Lincoln once said. So what about the drop jump test? Well, these videos here are from a long time ago when we started working in this field, because we thought it would be a really good idea to just look at how athletes are jumping, and you can really see how the girl on the left has great control while the girl on the right is falling into a valgus position, the one that we think is the risk position for an ACL injury. And what inspired us to make these videos and give the talks on how great this is was this study by Tim Hewitt, who actually won a prize by the American Orthopedic Society in 2005, a prospective study with 205 female athletes. And in that group of 205, there were 9 who went on to have an ACL injury. And as you can see from the slide here, there were differences between these groups, especially as it relates to knee abduction, in other words, in knee valgus. And the main conclusion of this study was that valgus motion and valgus moments can be used to predict an ACL injury. This is the conclusion. So, check. We've done the study on drop jump tests to identify this as a risk factor. But then if we look a little bit closer at the data, and this is the figure that is in that paper, and I spent a few hours transforming these data, counting, to get them into the distribution that I showed you earlier here. So this is a number of athletes on the top, and then their knee abduction moment on the horizontal axis. So this is the actual distribution of the 205. As you would expect, you have a normal distribution of knee abduction moment. And you also have a couple of athletes, 3 that are outliers to the right here. And you would think that, okay, these are the ones then that will have an ACL injury, right? But if you look at who actually got an ACL injury, okay, 1 of the 3, and the others are distributed within the larger group of athletes here. So if we then draw our line here and say, this is the cutoff for you having increased risk, you see with your own eyes that we capture only 1 injured athletes. In other words, there's a ton of false positives and many, many false negatives. So it doesn't really work. If we move it further, so we capture 8 of the 9 injured ones, the problem with that is that we also capture half of the others. So again, I would say that this test, not sure that this can be trusted to identify the injured athletes with sufficient test properties. But this inspired us to do a large prospective cohort study in Norway with Norwegian football and handball players. The study went on for 7 years and included a cohort of about 700 athletes in the end. You'll see different numbers for the different data sets that I'll produce here. And for the first paper that was published, there were 42 non-contact ACL injuries. And the question was whether this knee abduction moment, which was the one that we thought would be the revealing factor, could separate the ones with injury and not injury. So a much larger cohort. Here is the outcome. You can clearly see there's no difference on the group level even between the ones who did have an injury and the ones who didn't have an injury. And at the same time, with our Finnish colleagues, we started a study on younger athletes. So the ones in our group were adult female football and handball players. And this is a group of younger athletes to see, well, in this group, maybe the sort of the younger, scrappy ones, these are the results from the Finnish study, the distribution. And again, no significant difference even at the group level. Cannot be used as a screening test. What the Finns found, though, was if you look at peak ground reaction force in this, and what peak ground reaction force tells you is how stiff is their landing, how stiff is their jump. Do they go down softly and come up again, or do they sort of bounce off the ground? And here, there was a significant difference. I doubt, if you look at the graphs here, that you would think that this is a great screening test. The problem was that with the adult players, we couldn't reproduce that finding. There was no difference in stiff, soft landings between those who went on and those who did not. So we have looked at various ways of assessing these tests, and a lot of people are trying this in their clinic. So we thought, well, if we look at this and not use advanced what is it you usually call it, Roald, the whole catastrophe of markers and so on in the lab, but just simply video them from front, then stop the video at the point where they are at the maximum valgus angle. And we did this too. This includes 778 knees and 56 new ACL injuries, and this was the conclusion of the study. What that says did not work. Then we thought, well, the human eye and the human brain, especially if you were a really experienced physician or physical therapist working with athletes, if you sit there and watch this athlete, you're going to pick up all the telltale signs of someone who doesn't have knee control versus someone who has knee control. So what did we do? We put videos of 100 of these athletes on the internet, invited experts around the world, and 20 of them went on to have a new injury. So there were 80 who didn't and 20 who did. And there were 237 assessors. Maybe some of you here in the room did this assessment and scored them as being at risk, low risk, or being at high risk. This is the conclusion of that study. Poor test. And here is this famous curve that I talked about. And what this curve shows is that we're back to 50-50. It really is just plain guesswork of who is going to get an injury and who is not, based on a drop jump test. But then maybe you think, well, this group, who were they really? Were they really experts? What background did they have? I'm a physio. I'm probably much better than those orthopedic surgeons who did that, or the other way around. I'm an orthopedic surgeon and those physios are dumb, so they didn't do it right. So this is a score per group here. Physicians, coaches, physical therapists, and the number is that mean number you see on the screen there. If it's 0.5, it's like flipping a coin. There's absolutely no difference between people regardless of their expertise or background. In other words, does not work. Pretty negative story this guy is telling this morning, isn't it? So the new kid on the block is artificial intelligence, obviously. So what if we use machine learning and put not just a drop jump test, but all the full battery of tests that was done on these athletes, strength tests, balance tests, cutting tests, full biomechanics, you name it, everything that was done. So for this, we had data for 791 knees football and handball players, who altogether suffered 60 new ACL injuries, so 8% of them, in other words. Unfortunately, the conclusion of the machine learning exercise, the thing that is much, much smarter than us, was that the included variables could not be used for ACL prediction in practice. In other words, does not work. Sorry about this, being very negative this morning. All right, so a big red cross for 1 and a big red cross for 2. In other words, there's no point in doing 3 because, well, I already explained why 3 is not necessary. None of these tests work. If you have another test you think might work, well, tell me about it and we'll test it. But what if we use a much stronger risk factor for injury than these tests? And then the question is, what is the strongest risk factor for ACL injury? Some would say the coach. Probably not his fault that this guy is lying around on the pitch all the time. No, you're absolutely right. Previous injury is the strongest risk factor. And that factor varies a little bit between studies, but if we look at the actual data I've just shared with you, these are the figures. So on the right side, you have those who did not have an ACL injury prior to this. And then on the left, and this group, there were 6.5% of the athletes who had an ACL injury when we monitor them prospectively for a number of years. And on the other side, you have 86. So those are the knees where there is a previous ACL injury, 15%. In other words, there's a 2.3 times greater risk for those who have a history of ACL for having a new ACL. We knew that, right? But the question is, what does that mean? Can we use that as the predictive factor then to separate into high and low risk? Well, I've tried to depict the data in the same way as before. So on the left, you have the ones who have a healthy knee. On the right, you have the previously injured knees. So we have 86 previously injured knees in the equation, and we have 784 healthy knees in the equation. And here are the injuries. So while the risk is 2 times 3 greater, if we use that to identify the athlete at risk, we would identify these 13 who did have an injury, but we would miss the 51 who also had an injury but had a healthy knee to begin with. So if we use history of ACL injury to predict who will get injured, we will not be doing a great job. 93% of the predictions will be incorrect, and we'll miss 80% of the cases. So a big fat line across all of these 3. Sorry about that. And the question you're asking yourself is maybe, why? Why is it so difficult to predict? Well, I did share this with you. Injury is a result of a complex interaction between different factors, and this is just the simplest model. There are more complex models. Here is one. There's at least 2 or 3 more that I could put up here, which clearly show that injury prevention is difficult and injury prediction is difficult, as you can see on this video. So the answer to why is, well, shit happens. Yeah. The interactions in sport are unpredictable, and they will result in injury. So depressing morning, folks, isn't it? And then some of you are asking yourself, well, do we not have a bunch of different screening programs in public health? We have them for breast cancer, prostate cancer, cervical cancer, for cardiovascular disease. National programs funded by the government, right? Well, it has to do with the interventions as well. You have to consider that. The interventions in each of these cases are pretty significant. It's not something you do lightly. But what are interventions in sport? Well, stuff like this. Cheap, no risk. Why shouldn't you be doing exercises like this alpine skier here is doing to protect her knee. And we do have research to show that targeted exercise programs not just can reduce, but they will reduce the risk of ACL injuries by about 50%. That is the number that I normally quote. And we're so fortunate that there's now a bunch of reviews and meta-analysis done on the existing studies. I've counted, maybe there's more than 14, but I at least identified 14 reviews and meta-analysis since 2012. Unfortunately, no studies since 2012. And these are results. This is for any knee injury. Odds ratio of 0.54 means a 46% reduction if you do these programs. And I should add that these meta-analysis or systematic reviews, they put all of the studies in, even the crap studies, even the studies where nobody did the exercises are in this. So the real effect is probably bigger than that if you actually do the exercises. So for all ACLs, 40%, but for non-contact ACLs, 65% reduction of ACL injury rate, even if you have the crap studies in the mix. But you should also note that out of all the studies that are quoted in these meta-analyses, there were really only 2 studies that were designed and powered with ACL injury as the outcome. The others had knee injury as the outcome. So there's more that can be done in this field. The reason why there's only 2, you can see here probably, it takes a large study, 4,500 athletes in the Swedish study, because ACL injuries, although they are common, they're also rare, if you like. So what type of programs are we then talking about? Well, I'm sure everyone in the room and everyone watching this on the internet are aware of the FIFA 11 Plus program. That is one example of a program that reduces the risk of ACL injury also in adult elite athletes, both female and male in the college level, has been clearly showed. What characterizes all these programs, though, if you work with elite athletes, is that these are one-size-fits-all programs. You'd give this program to the whole team. And you're meant to do the program as it was prescribed originally when we did the first study to show that this worked. But if you're working with elite athletes, you're probably not going to be doing the 11 plus every day. And these are some videos from the Norwegian Olympic Training Center with some alpine skiers and what do we have here? Athletes from different sports doing their basic training exercises to prevent injury in general and prevent ACL injury in particular. And you can see that these exercises are quite more advanced than the 11 plus program. And here in Qatar with the ASPREV and NSMP team, we are using a little bit of a different approach, which is termed risk management. And there isn't time to go into detail on what that means in this talk. But basically what we're doing or trying to do is use all the data we have available on the injury profile and the risk for each athlete and for the team as a whole, identify these, and then create a dedicated plan, a risk management plan to try and alleviate the risks that we think that we can do something about through exercises or through different things. So in other words, it isn't a one-size-fits-all program, but is a made-to-measure program with one example on the slide here, and this is the one that the Al Khateria team, sorry about the pronunciation, produced a few years ago. And we have gone on to advance this further into a toolkit of 23 different focus areas, we could say, which the doctors and physios and fitness coaches in the professional league here in Qatar think are the most relevant ones for them to work on, to address in order to prevent injury and illness and keep the players healthy and performing. We call this the IP2 program. One example, sorry I put the wrong example, this is for the hamstring injury. fact sheets, this is how it works, this is how you do it, and posters and other tools in the toolkit that the team can use to inform players and complete these programs that result from their risk management plan. In other words, for a made-to-measure program, we are supplying the building blocks, thinking that, well, Team A might want to build a house like this, whereas Team B needs a house like this, so it is not one size fits all, but it is made to measure. So the take-home message, the main take-home message today, is do not try to predict future injury based on screening tests. This is simply not possible. But that injury prevention programs should target all the athletes in high-risk groups. So maybe you will not be doing ACL programs if your sport is archery, but you certainly should be doing it if your sport is football or handball. And the other take-home message is that proven programs exist. And finally, for those of you out there working in youth sports, adolescent sports, some tips on where you can find resources that can help you use these programs in your daily practice. And the first tip is the app called Get Set, Train Smarter, developed with the IOC over the years. Available, this shows 8 languages. I think by 1st of January there will be 10 languages. So download the app on either both for Android and for iPhones. And in this app you can build a program, pick a program for your sport, pick a program for your injury type, so knee injury is also a possibility. And you can also design your own program based on this. And if you go to a website called fit2play.no, then you will find the exact same programs. Plus on the website there's much more information than just the exercises, which exist for all of the Olympic sports and also some non-Olympic sports. So there are programs for prevention of injury in each of these sports. There are programs for each of the body parts that we're interested in, and the videos are explained, and there's much, much more. But the final tip is this. If you really want to learn about injury prevention, then please come to Monaco, where the 7th IOC World Conference on Injury and Illness Prevention in Sport will take place over 3 days. I'm delighted that I know that there's a large group of professionals from Aspetar and our NSMP programs who will be there as speakers. I think we have a fantastic program. So if you come and you're not happy after the conference, I will personally refund your registration fee. Did I say that out loud? Sorry. Thank you very much this morning.